Okay, guys. So the first three lectures are sort of an overview for the first two-thirds of the block. It says the lectures are on the heart. In fact, what we're going to do is we're going to go around the cardiovascular system. We're going to introduce relevant concepts broadly. And the reason we do that is because what we're going to do is we're going to start doing detailed lectures on components after that. You'll get cardiac muscle, smooth muscle, the autonomic nervous system, which is how the body controls the cardiovascular system primarily, okay? And in order to fully understand the function of all those little individual components, it helps to be able to fit it all into the big picture. So these are big picture lectures. Not all, but much of the material will be repeated in later lectures as people go into more detail. And not all, but some of this will be review. For instance, the cardiac action potential is discussed in very general terms. The one reason for that is because when I used to do this lecture, it was the very first one that you would get at the beginning of the semester, and nobody had the action potential left yet. And I debated as to whether to take that section out and decided not to. It's a reasonable review. We can do it really quickly, okay? So if you find yourself getting lost because you think that the stuff's coming too fast and you can't remember it all, don't panic, okay? It'll be coming back again, and really in most cases again and again and again, okay? So don't worry about it over much, okay? So the course notes, your reading material, have clinical correlations. You are not responsible for those. They correlate the material with clinical application, and we'll worry about that in the future, probably mostly in the second year as far as these lectures are concerned. Commentaries are just things that I've been asked about that I don't think the average student needs to know, but if you want to know answers, there they are. So they're usually FYI, more details. And then case studies you are responsible for. Generally speaking, they will cover the cases for the block. You will get the first one, Lloyd Carthen, next week, okay? So I am going to start with a case. It is very similar to Lloyd Carthen. It's not exactly the same, but you will see why I'm starting with it and why I chose it, and why you might as well be looking at Lloyd right now in many, many aspects, okay? We have a 65-year-old woman who has shortness of breath. She can only walk a few steps without getting severe dyspnea, okay? So she's in reasonably bad shape. The stuff in red is the stuff to pay attention to. She has lower extremity swelling. She has abdominal distension that has developed over the last 5 months. She is unable to sleep in bed and is using an upright chair because she can't breathe. She gasps for air if she lays down. She has previously been shown via echocardiogram to have dilated cardiomyopathy, so that is the primary cause of this. Her heart rate is 131, high or low? High, good. Respiratory rate is 24, that's high. Blood pressure 112/76, probably within the normal range, maybe moderately low, okay, but not bad, all right, given all the other things she's showing. She has JVP, that's jugular venous distension. You can literally see the pulses in her jugular, which you're not supposed to be able to see, 7 centimeters above the sternal angle. She has a holosystolic murmur. She has rales in her lungs, 2/3 of her lung fields. And the physical exam confirms the lower extremity edema. She can't fit into her shoes, okay? This is her chest radiograph. Now, I am not a radiologist. I do not pretend to be, but I do know that when you take a radiograph like this, your heart is not supposed to look like a basketball, okay? So this is very enlarged, okay? Her lung fields have something very unusual in them. They should be more clear than this. You see these white lines? Those are veins, blood vessels in the lungs. And ordinarily, you can't see anything like that to that kind of an extent at all, okay? So her veins are distended, and she has fluid in her lungs, okay? The echo reports an ejection fraction of 5 to 10%, high, low, normal, exceedingly low. We'll talk about that. She has mild regurgitation. Her pulmonary arteries have an estimated peak pressure of 50 millimeters of mercury. Okay. By the time we hit November 16th, you should be able to hit every single one of the things that I outlined in red and explain them mechanistically and tell me orally or on an exam exactly why each and every one develops. Okay, this is called congestive heart failure. The cardiovascular section of this block is oriented around it. Very common disease, and it is a wonderful way to learn the physiology of the cardiovascular system because it's a prime example of physiology gone wrong, okay? So each one of those red things, bear it in mind, and maybe when you go back to study for the exam, you can take a look at them and make sure you understand exactly why each one develops, okay? And we will bring this case back and Lloyd over and over and over again during the block, okay? So a quick introduction to the heart and the cardiovascular system. I think you guys know this. It supplies the entire body with oxygen and nutrients. The heart is a pump, and the cardiac output, that is the liters of blood per minute that your heart pumps, is 5 liters per minute. And that is 10,000 liters per day. It's 4 million liters per year. That is enough to fill this lecture hall, okay? So it's a lot of blood for a little organ the size of your fist to pump, okay? And keeping it healthy and functioning is fairly important. Your body knows that. When you hemorrhage and you lose a lot of blood or something like that, what happens is your body cuts off the circulation to every other organ in your body except the heart and the brain. Those are the 2 last ones to go because it knows the value of each one, okay? Cardiovascular disease, most common cause of death in the U.S. and the world, and it has been for quite some time now, okay? So what drugs do we use if we have a patient with cardiovascular problems? Digitalis, you do not need to know the drug names for this lecture. When you have pharmacology, you will. If I were to ask you a question on an exam at this point in your education, I would tell you that it's a sodium-potassium pump inhibitor, okay? And this will be used to cause your heart to contract with more force of contraction. We'll explain the mechanism behind that. I will explain it. Dr. Ramos-Franco will explain it in detail. At least she has in the past. And hopefully you will understand how that happens. It is a very interesting cascade of events that really is a nice way to review how the cardiomyocyte functions. You will note that these drugs have their effect on proteins, microscopic organelles, okay, the biochemistry of the cell. And what happens is this results in effects in the patient that you can see, okay? Inhibit sodium-potassium pump, increase calcium, increase force of contraction, increase stroke volume, increase cardiac output, increase blood pressure, increased perfusion to the tissues, your patient feels better, okay? You should, by the time you're done with this block, be able to trace the pathway back and forth between the two. Start with the proteins, work your way up to what you see in the patient, go from what you see in the patient, work your way down to what proteins or at least what cells or organelles might be involved. And for many, if not the majority of the diseases that we introduce, we expect you to be able to do that, okay? So it is important to learn this system on every single level, the level of the molecules, the organelles, the cells, the tissues, the organs, and the system itself, okay? And you need to be able to trace back and forth how these things work, okay? That's the great thing about this block. It allows us to do that. You have progressed to a point in your education to where this is the first real organ system, in my opinion, that you have. And it's the first one where you'll actually be able to do this. And that makes it really cool, okay? Sympathomimetics act through G-coupled receptors. I think you guys certainly have learned about those already. And ultimately modulate ionic channels. They mimic the effects of the adrenergic nervous system, the sympathetic half of that system. And that is why, in part, Dr. Cohen will stand up here and bore you with lectures on the autonomic nervous system. When you treat the cardiovascular system, you will frequently be doing that by taking advantage of the way that nervous system works and trying to manipulate it so that you can make your patient better, okay? Phosphodiesterase inhibitors inhibit the breakdown of cyclic AMP. You guys probably have an idea now as to some of the things that might do. It is an important second messenger system, okay? And we will trace things up and down the ladder from the receptors and the second messenger systems up to the effects, particularly in the autonomic nervous system. Calcium channel blockers, we're going to talk a lot about the action potential and a lot about things like calcium entry across cell membranes and what effect that has in cardiac and smooth muscle. And if you add a calcium channel blocker, you will alter that. And hopefully you will alter it in a positive way, though there are side effects that you should be aware of, and you should be able to point those out based upon the molecular mechanisms too. Beta blockers, once again, address the autonomic nervous system. Your beta receptors are a part of that system. That's the reason why we learn it. And the antiarrhythmic drugs will bring you back to the action potential and how it propagates around the heart over and over and over again, okay? And we'll talk a lot about that. I will introduce you to those in a lecture late in that section. So let's talk a little bit about the heart itself. We have 4 chambers. We have the right atrium. We have the left atrium. We have the right ventricle, and we have the left ventricle, and those are separated by valves. We have the right atrioventricular valve, also known as the tricuspid valve. Notice the 3 cusps, okay? And that separates the right atrium from the right ventricle, and indeed blood is going to flow from the atrium to the ventricle through that valve, and its function is extremely important. The left AV valve, or the mitral valve, separates the left atrium from the left ventricle. Blood will flow through that, and its function fairly important. The aortic valve and the pulmonary valve are the semilunar valves, and they separate the left ventricle from the aorta in the case of the aortic valve, and the right ventricle from the pulmonary artery in the case of the pulmonary valve, okay? These all have an extremely important function in the cardiac cycle, and you should learn when they are open and when they are closed in that cycle. And I will talk about that. So a quick round the horn in terms of how your heart operates. We have systemic blood coming back from your circulation. It is not oxygenated. It is coming back through the superior and inferior vena cava, and it is dumped from there into the right atrium, okay? And during diastole, that blood will flow from the right atrium down a pressure gradient to the right ventricle. So the pressure is fairly low on this side of the heart, but you should remember that it is slightly higher than the right atrium, than the right ventricle during this period of the cardiac cycle when the ventricle is relaxed. And blood flows from high pressure to low pressure down that gradient, okay? So if you want to determine the direction in which blood flows, remember the pressures. And that becomes fairly important right now as we talk about systole, where the right ventricle contracts, the pressure in the right ventricle builds, the right AV valve closes, and the pulmonary valve opens, and blood is ejected into the pulmonary artery. And at this stage of the cardiac cycle, the pressure is higher in the right ventricle than it is in the pulmonary artery, and blood flows from high pressure to low pressure into the pulmonary artery, and from there into the pulmonary circulation where it is oxygenated, okay, into the lungs. Blood is returned from the pulmonary circulation to the left atrium, okay, and during diastole, when the left ventricle is relaxed and the pressure in the left ventricle is low, and the pressure in the left atrium is higher than the pressure in the left ventricle, blood flows through the mitral valve, the left AV valve, into the left ventricle, and the left ventricle fills. The left ventricle contracts during systole, the pressure rises, the mitral valve closes, the aortic valve opens, and blood flows from the left ventricle where pressure is high into the aorta where pressure is also high, but not as high as the left ventricle, okay? And you eject blood into the aorta, and from there you go into the systemic circulation where it flows into a variety of organs, and then is deoxygenated, denutrienated, and returned back through the vena cava to the right atrium, and the cycle continues, okay? Very quickly, that's how the heart works, okay? I have pointed to the valves many times. There are two kinds of diseases of the valves that you should be moderately familiar with. One is valvular stenosis, where the valve is fibrotic and narrow. So if you have a narrowed valve, it is hard to force blood through that valve, okay? And you have valvular insufficiency. That would be where the valve closes, but it leaks. And when that valve closes, it should not allow blood to flow. But if it's leaky, then a little bit of blood will, okay? Those both cause murmurs, as we will talk about in a moment. So let's hope I execute this successfully. I did. This is her echocardiogram, okay? And this is her left atrium, her left ventricle, and her aorta, and you can see that these are all very big, okay? This is the left AV valve, the mitral valve, and this is the aortic valve, closing and opening. And you can see them closing and opening on this is a very good echo. Now, you see this blue right here? That when this valve closes, you get this blue stream. That's because she has an insufficient aortic valve. That means that that valve is closing, but it's not stopping blood from leaking back through the valve. And what you see is it's a Doppler measurement that shows you the turbulence in the blood flow. And turbulence is what you hear as a murmur, okay? So you typically get murmurs associated with valvular problems. So this is a good example of aortic insufficiency, and her mitral valve is a little bit insufficient as well. If you look, you can see some turbulence here as well when that closes, okay? This is covering up her name so that you can't see it. I've not had a chance to alter this video to clean it. But nevertheless, it serves its purpose. So this is what the valves look like when they're going badly, when you have insufficient valves, and they're leaking when they shouldn't be, all right? let's get our PowerPoint back up. And she's covered up. And I never get tired of looking at that echo. I think it's fascinating. So she has a holosystolic murmur. And that murmur is being caused by one of those insufficiencies. And in fact, by the time you're done, you should be able to tell me which one it is, okay? Because only one of them is going to show up during systole. The other one will show up during diastole, okay? So bear that in mind. I just wanted to point it out. The turbulence that you see is what you hear, or it's the result of that turbulence, okay? Okay, so, and that's what I said. We'll talk more about turbulence in the coming weeks, but I think virtually everyone will talk about these murmurs in the cardiac cycle lab that's coming up for you guys. The heart is actually made up of two pumps. There's a pump on the right side, there is a pump on the left side, and each of these ejects blood. And it is fairly important that you recognize that these pump the same amount of blood. They are in series. When we say two things are in series, that means that one receives the entire output from the other. So everything that comes out of the right heart is received into the left heart, okay? And when you look at these, the heart in anatomy and probably in histology as well, you will notice that the left wall is thicker than the right wall, and that will lead you, sometimes even as clinicians, to tell people that the left heart puts out more blood than the right heart because it's stronger. That is incorrect. That cannot be. If I am putting out more blood on the right side than the left, then my lungs blow up with blood like a balloon until they burst because blood accumulates there. The left side has to remove whatever the right side ejects, and the right side has to remove whatever the left side ejects in a normal person, or you can't function. You'll burst with blood, you know, your capillaries, okay? So bear that in mind. The flow has to be the same on both sides, okay? The pulmonary circulation is in series with the right and left heart. It receives the entire output from the right heart. The left heart receives the entire output from the left heart. The walls in the pulmonary system are highly compliant. And what that means is that for the same volume, they have lower pressures, okay? The walls are stretchy, okay? And so the pressure on the right side is only about 20 to 25 millimeters of mercury, whereas the pressure on the left side in the aorta is like 120, okay? So the pressures are lower in the lungs, and as you will learn, that's a good thing. She has an estimated peak pressure of 50 millimeters of mercury. That's roughly double or more of normal. And we'll talk about why that is, okay? The systemic circulation perfuses everything else. It all comes out the aorta, and the circulation is split. And it's split and flows across different capillary beds. So each of these capillary beds receives a portion of the left cardiac output. So we say that those beds are in parallel, okay? And what your body does is it tries to keep blood pressure the same in the aorta and the large arteries, and what it does is it regulates flow to each of these capillary beds by contracting and dilating vessels. So it regulates each flow to each organ system in accordance to its needs and the needs of the body. But and that's the way the cardiovascular system operates. It's a constant driving force, and you vary the resistance. You'll learn what that is if you don't understand it now, okay, to determine what the flow is to each tissue. I do want you to notice this figure is all over your notes. It's a nice figure in that it's real data, okay, but do note that the aortic pressure appears to rise above the left ventricular pressure during ejection. You guys all know, because I have repeated it a couple times now, that is impossible. You cannot have higher pressure in the aorta than in the ventricle and have blood flowing into the aorta and being ejected. This is an artifact of the data, when you do real measurements, you get artifacts where something, little variations in the data make it look like something is a little bit higher or a little bit lower than it should be, okay? In fact, I assure you, in this patient, like every other, the pressure during that phase is lower in the aorta, so don't make that mistake, okay? Even though it looks that way, it's not, okay? And I wanted to point that out because, you know, I don't want you to be confused by that. I'm stressing that over and over and over again. It's how hemodynamics works. The cardiac output, as I said before, is the amount of blood that leaves each ventricle per minute. It is calculated as heart rate times stroke volume, okay? These are what you call causal relationships, and the reason they're called that is because the body varies the heart rate and the stroke volume in order to alter cardiac output, okay? We'll talk about why that is in a couple weeks. For now, note that the heart rate is normally about 70, and you can vary that over a very wide range, 60 to 180. It is controlled by the autonomic nervous system, and it is the primary way that your body controls cardiac output. The reason it's the primary way is because there's only a limited amount you can change the stroke volume. So the heart rate, changing the heart rate allows you to change the cardiac output in a much more dynamic way over a much greater range of values, okay? And if normal is 70 and 72, that's about 5,000 milliliters per minute. That's 5 liters per minute, okay? The stroke volume is controlled by preload. Preload is how much you fill your ventricles. The more you fill them, the more you stretch your muscle, your cardiac muscle. The more you stretch cardiac muscle, the higher the force of contraction and the higher the stroke volume, okay? You guys remember that being true for skeletal muscle up to a peak, and then after that peak it dropped? Well, in cardiac muscle, it only goes up to the peak. It does not drop, not in normal cardiac muscle, okay? Dr. Ramos Franco will talk to you about that. I will certainly talk to you a lot about it. But as you increase the preload, you increase force of contraction. That increases the stroke volume. Increasing afterload, that is the pressure against which the heart must contract. It limits stroke volume. It cuts it down. So the harder your heart has to work to eject that blood, the less blood it ejects, okay? The third thing that controls the stroke volume is the inotropic state or contractility. I like the term inotropic state because it's clean. Contractility is a constant source of confusion to students and everybody else because it sounds like you're talking about the force of contraction. You are not. Contractility and inotropic state are alterations in the state of the muscle to make it contract, say, via a drug or a hormone or a neurotransmitter, okay? Usually it happens because you've increased calcium in the cytosol of the cardiac myocyte, which causes it to contract to a greater extent, okay? Usually, but not always. Contractility is not how hard your muscle will contract. That is the force of contraction. Contractility has a special definition. It's what we mean when it's a change that you get when the muscle is diseased. That would usually be a decrease in inotropic state or a decrease in contractility, or when you've treated it to make it contract harder in the face of a drug. And that will cause an increase in the force of contraction, okay? It's a change in the state of the muscle. Preload does not change the state of the muscle. That's just a normal way that it functions. You actually change the state when you alter the contractility. Again, inotropic state or contractility altered by calcium in many, many cases. The majority will be you treating a patient with a drug. If you have an increase or a decrease in functional myocytes, for instance, you can cut the coronary artery supply off, those muscle cells may not function too good. So you've effectively decreased the number of functional cardiomyocytes. That is a decrease in inotropic state, okay? Okay. So here's our patient. Blood pressure, low, normal, okay? Heart rate 131. Heart rate, high, low, or normal? High, very good. Okay, normal about 70. Okay, so given that that's the case, given that her blood pressure is almost normal, if not normal, well, let's assume that her cardiac output is normal, 5 liters per minute or maybe just below that, okay? With that heart rate being high, what can you say about the stroke volume? Low, very good. That would be something that I could ask on an exam, you know, those kinds of questions, because I'll want to know if you know the relationships. If the heart rate is high and the cardiac output is normal, then the stroke volume must be low, okay? And all you have to do is look at that equation and you can see that, okay? You can't have high times normal and get normal. It has to be high times low, okay? Good. So we say that her ventricular muscle is in a negative inotropic state. It is not contracting well, and her stroke volume is down, okay? Okay, I'm going to use the last 10 or 15 minutes to talk to you a little bit about the lungs. You can set down your pens or your keyboards and just listen, okay? You will hear about this again after Thanksgiving, and that is when you need to know it. What I'm doing is I'm giving you a very brief introduction because I know that you're going to be cutting into a cadaver very shortly, and I'd like to be able to give you a little bit of function before you do that, so that when you're looking at the anatomical structures, you'll go, yeah, I know what that does, okay, basically, all right? So the first thing I want to show you is how the lung normally functions during inspiration and expiration. So you have your diaphragm. When your diaphragm contracts, it actually protrudes more into the abdomen and it expands your chest cavity, okay? It increases the volume of your chest cavity. And what that does is it creates a negative pressure, okay? You've got so much air in your lungs. Now you increase the volume suddenly, and you've got the same volume of air, the pressure must be down. That's basic physics, okay? And that's essentially what's happening. So you create a negative pressure. The air is atmospheric. The lungs are now less than that because you've expanded the chest cavity, and air flows from high pressure to low pressure through your mouth, down your trachea, and out all those little structures that you're going to learn about, and into the alveoli, and you get air, and you bring air into your lungs. Inspiration, okay? Expiration, the diaphragm relaxes, protrudes back up into the chest cavity. You've got the same amount of air, but now you've got less volume. So you build a positive pressure in your lungs. The pressure is now higher in your lungs than atmospheric, and air flows from high pressure to low pressure out through your mouth and into the atmosphere. Expiration, okay? So, the space between the lungs and the chest wall is a vacuum. It is the pleural space. It is a virtual space because it should have basically almost no volume, okay? And that means that your chest wall and your lungs are stuck together. So what's going to happen when you cut into your bodies, into the chest? What's going to happen to the lungs? What do you think? Anybody ever watched like any of the Million Doctor shows on TV? I can't believe, yeah, collapse, pneumothorax, thank you, okay? So what happens to the chest wall? Tougher question. Protrude out, outstanding. It protrudes out. Probably not a lot, but it does, okay? Here's the reason why. If you look at your lungs, if I'm holding the lungs by the trachea right here, at atmospheric pressure, they want to be basically zero volume. And they're always trying to be zero volume when they're filled with atmospheric pressure. That's what they want to do. So they are always pulling away from the chest wall, trying to collapse. If I'm sitting at rest and I stop my breathing and just rest myself, I'm at what's called the functional residual capacity. That's the FRC. My lungs at that point want to collapse, okay? They want to be zero. My chest wall, on the other hand, wants to have a fairly high volume, okay? If I were to take the lungs out and look at the chest cavity, it would have a higher volume than it would normally have, okay? And what happens is these two things are stuck together, and your lung is trying to pull downward and collapse. Your chest wall is trying to pull outward and expand. And your functional residual capacity is where the two balance out. And you can hold that volume with no effort because it's a natural function of your lungs and your chest with no effort on your part, no muscular function, nothing, okay? So that saves energy. And now when you breathe, you inspire and expire, you're basically doing a seesaw across that functional residual capacity, okay? And that makes it easy to breathe. It allows you to do that, expand and contract your chest with minimal effort, okay? So that makes it very easy. When you disrupt that balance, you get a problem, and it results in disease. And you will do a disease where you disrupt it, okay? And it causes you a great deal of problem because it causes your breathing to be labored, and you have to put forth a great deal of effort just to breathe. And as it turns out, and they have actually done this calculation, you eat up a significant portion of your metabolic energy doing it. And that is one reason why people with respiratory diseases tend to be thin, okay? At least with certain types, okay? And that's pretty much what I said there, okay? So your ventilation is the process, expiration, expiration, move air in and out of the lung. Tidal volume is the volume that you inspire and expire in a normal breath. The minute ventilation is the volume of air that enters or leaves the lungs per minute, okay? It is regulated by metabolic need. You have chemoreceptors that sense oxygen in your carotids and carbon dioxide within the brain, and they sense when those values are abnormal, and they cause alterations in respiration when that happens. Your minute ventilation is the frequency times the tidal volume, the amount that you're moving in and out per breath times the number of breaths. That should look very familiar. It should look a lot like cardiac output. Your minute ventilation is the cardiac output of your lungs, okay? It's cardiac output, frequency of beats times volume per beat. Minute ventilation, frequency of breaths times volumes per breath, okay? So when you come to that, you'll go, okay, it looks just like cardiac output. I'm not learning anything new here. The terms change, the concepts are the same. All right. Gas diffuses from high concentration to low concentration. So if I have high oxygen in my alveoli and I have low oxygen in my lungs, it will diffuse across the alveolar wall to replenish the oxygen in my blood. Okay? The concentrations of the gases are measured in partial pressures. This confuses people to no end. I do not blame you. For instance, air is 79% nitrogen. So when somebody asks how much nitrogen is in air, they will, what's the concentration? They will frequently be asking you what the partial pressure is. That means you take the atmospheric pressure, 760 milligrams of mercury, you multiply it by 79% and you get 600. That is the partial pressure of nitrogen in air, okay? The partial pressure of oxygen is 21%. That makes it 160 in air, okay? But here's the problem. If only it were that simple. then your partial pressure would be 160 in your alveoli, and we would have no issues. But the problem is that as air goes down into your lungs, it becomes humidified with water. Water is added to the air, and in the end, it accounts for 47 millimeters of mercury partial pressure once you get down deep into the lungs. So now, because we've added water to the air, we have the same atmospheric pressure as 760, but now our 21% gives us 150 millimeters of mercury, because we're talking about 21% of whatever's left over after this 47 is contracted. So the air is roughly 6% water, the percentage of oxygen drops. I'll go over something else that may help with that in a second. The partial pressure of a gas dissolved in liquid is just the partial pressure of what the atmosphere is above it. So if you saturate the liquid with the gas and you measure the partial pressure of the atmosphere just above it, that will tell you what the partial pressure is in the fluid. In this case, we're talking about blood, okay? So here's another way to look at partial pressure, and I'm going to bring it back in terms that we're familiar with, okay? This is our old osmolarity figure, where we have a liter of water, okay? And on the left, I have a liter that is pure water, nothing in it, 100%. And then on the right, I have a liter that has particles in it. And those particles take up volume. My concentration of water has dropped. Okay? That's what osmolarity is. And when we get water diffusing from high concentration to low concentration, it goes from low osmolarity to high osmolarity because it's diffusing down its concentration gradient. Okay? Oxygen and all the other gases are no different. If I said on the left, you have a liter of oxygen, and then I said on the right, you have a liter of oxygen, but I've added water, and those water molecules take up space, that means the concentration of oxygen is dropped. That's why the partial pressure of oxygen drops when you add water to air. The concentration of everything in the atmosphere drops when you add anything, because the water takes up space, and what happens is you have fewer molecules of everything else. So the partial pressure drops. That is why they measure things in partial pressure, or at least that's how they do it, all right? And that's what we mean when we say the partial pressure is dropped. It's because you added water and it takes up space in the same liter. In this case, it takes up pressure in the same 760. Go ahead. Your atmospheric pressure in your the pressure doesn't go up in your lungs. It displaces molecules. Gas molecules move around. So when you add those molecules, it simply displaces them. What that means is, that's just fewer oxygen molecules you can bring in because they're taking up space in the atmosphere in there. Okay. Okay. So hopefully that helped. We'll see. Not something to worry about excessively at the moment, but it's helpful to get introduced to it now. Note that diffusion is not effective over long distances, so we have to keep the barrier of exchange thin. In fact, it's only 1 to 2 microns, made up of type 1 alveolar cells, capillary endothelial cells, and their basement membranes. You can see, this is the alveolus. You can see through that membrane the shape of the red blood cell in that capillary through the membrane. And that tells you how thin it is, okay? You want to keep that barrier as thin as possible to make diffusion easy. So if I put a bunch of water in the lungs, and I put a bunch of water in the interstitial space, and I have a little bit of water and it accumulates in the alveoli, what do you think that does to the distance of diffusion? What do you think? It increases it, thank you. Okay? So if you increase the distance of diffusion, that's going to, that could provide a limitation for how much oxygen you can get in. There are other reasons why why pulmonary hypertension, fluid in the lungs, will limit breathing. We'll leave that to Dr. DeCourcy, okay? But I wanted to emphasize, you know, you can't thicken that barrier of exchange without consequences. The last thing I want to cover, and I'm pretty sure you've had this already, the majority of the oxygen is carried in red blood cells bound to hemoglobin. It increases the capacity of the blood to carry oxygen 65 times. Carbon dioxide is carried in 3 forms. A minority is dissolved. A little bit more is bound to hemoglobin and protein. And in carboamino complexes, and the rest, almost 65%, is bound up in the form of bicarbonate. So what your red blood cells will typically do is they will take carbon dioxide and water and convert it to bicarb. And that allows you to transport a great deal of carbon dioxide. Okay, because you're taking the free carbon dioxide out of solution and you're converting it into bicarb. Okay, carbonic anhydrase comes back to haunt us. We learned about that in the last block, and now we have it again. Okay, and you're going to see it again. This is a very common reaction to generate protons and bicarb. In this case, the idea is to generate bicarb so that you can conveniently transport carbon dioxide. You're not just limited by the solubility in the plasma, okay? All right, so that's it. Let's take a break. We'll start again at 10. We'll do the second lecture. We'll expand upon this, okay? Thanks.